Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors Vivian Leigh, Aaron Lacey, Rebecca DeFabio, Jason Lesnick, and Clay Smith. Okay, so the first article, which was titled Pursuit of Optimal Vagal Maneuvers in Stable Supraventricular Tachycardia, a Network Meta-Analysis, out of the Western Journal of Emergency Medicine. Okay, so, a patient comes in, their heart rate's really high, they've got supraventricular tachycardia, SVT. The first step is, of course, vagal maneuvers. Not because they work every time, but because they're very non-invasive. I find the success rates a little bit low personally. Some people really say that it works every time for them. Maybe I'm not doing it that well, I'm not sure. But it doesn't seem that complicated, so I don't see how badly you could do it, really. Either way, you give it the good old college try whenever they come in with it. Though I do find a significant number of patients do convert when they get an IV or something like that, just as they're coming into the emerge. I've definitely had patients who have a long-term recurrent SVT, and they kind of develop their own vagal maneuvers without really knowing what they're doing. They just know that when they feel this way, they feel a flutter in their chest, they do this thing. A lot of them have a kind of variable things. Like I know one guy, he's like, well, I was just breathe through the sleeve of my sweater and then I would feel better. And he'd been doing that since he was a kid. The guy came in, he was like 45 or something. So I've always kind of felt like the people that are going to convert with vagal maneuvers would have converted already by the time they get to me. But nonetheless, you must try. However, you don't want to try all the vagal maneuvers. It's just going to be tedious. You want to essentially do the best one. And that's what these authors wanted to know. They wanted to do a network meta-analysis to compare different types of vagal maneuvers. And so they compared 4. They did the standard Valsalva maneuver. They did the modified Valsalva maneuver, which is you blow through a syringe and then once you're done doing that, someone lifts up your legs. They did a carotid sinus massage. And then they did a new one to me, which was head down deep breathing. Now, these are not the only vagal maneuvers. I'm not entirely sure why they picked these ones specifically. There's also the kind of the reverse Valsalva, which instead of trying to blow, you try to suck in the plunger of the syringe. We covered an article on that on the Journal Feed a couple years ago, and it seemed pretty effective at the time. But all the same, those are the ones they picked for this network meta-analysis. So they found 19 RCTs and totaled up to 2,500 adults, and then compared them. However, the vast majority of the trials were just looking at the modified Valsalva and standard Valsalva maneuvers. Well, the other ones, carotid sinus massage, sure, had a few patients, and then the head down deep breathing only had one single trial, so keep that in mind. Now, what they found was superiority of the modified Valsalva maneuver throughout, so it was statistically better than the standard Valsalva maneuver. So you had about a 2 to 3 times higher rate of converting to a normal sinus rhythm on the first try, and you also had lower rates of having to go to pharmacological management and higher rates of overall Valsalva success. Whereas when you look at the head down deep breathing technique and the carotid sinus massage technique, these were also better than a standard Valsalva, but not statistically so. And there was not a statistical benefit to the modified Valsalva over these other techniques. So this article was pretty clear that it seems like the modified Valsalva maneuver was the most effective as far as they looked at. But that's mostly because it has so much more literature behind it. I can't say for certain that it's statistically or clinically better than these other options because they're just not studied very much. So in the face of little evidence, I think it is very fair to start with the modified Valsalva maneuver, but you can't technically claim that it's the best, or at least not very with much assurance, because we just don't have the data for these other options. So if you like doing another one better, then I can't really say that modified is better than that technique per se. Unless you're just doing a standard Valsalva maneuver, we know that it's better than that. So in a spoonful, this network meta-analysis seems to confirm that the modified Valsalva maneuver is certainly better than the standard Valsalva for the conversion of SVT. Very recently, it should be your go-to first try before moving on to electricity or drugs. Okay, then let's skip to the third article. Titled, Timing is Everything, a systematic review of optimal repeat computed tomography protocols in traumatic brain injury, out of the Journal of Neurotrauma. So after you've had some kind of intracranial hemorrhage, it's common practice in a lot of circumstances that you're going to have to scan that patient again. However, the exact timing of having to scan them again and exactly which patients have to be scanned again, it's not entirely clear. And that's what these authors wanted to clarify a little bit for us, is when are we likely to see progression of a bleed and when not, so that we can better inform when to do those repeat CTs. Now keep in mind through this that just doing a repeat scan often doesn't change your management. If you do repeat scans as a result of a clinical change in the patient, then this leads to an intervention about 40% of the time. Whereas if you just do routine repeat scans, this changes your management maybe 1 to 2% of the time. And so for the most part, just routinely repeating the scans is not going to be very helpful. So they did a systematic review and found 26 studies that evaluated the timing for repeat scans. I think their search might have been a little bit too limited. There are almost definitely more papers out there that could have given them more information on this. For instance, the brain injury guidelines, big, most of those papers do contain data on repeat scans at 6-hour time points in much of these validation studies. And I think that could have contributed to this data. It's not going to tell you about all the different time points that they want to look at, but it would be a treasure trove of information about 6 hours. And they didn't seem to pull up any big articles from this search. So I think that maybe they were a little bit too selective on the articles that they found. Altogether, they did certainly find some information. For instance, scanning later, you're more likely to see some kind of a change. So about 66% of patients with intracranial hemorrhages don't progress anywhere past 8 hours. 94%, if you scan them at 24 hours later, you'll have caught 94% of any progressions. So most of the time, they're going to probably progress up front over the next 6 to 8 hours. But this was highly variable. Hemorrhage progression varied widely from 0.4 to 65%, and with also variability in the predictive factors. However, things that seem to be associated with predicting progression of a bleed were having a very early CT scan. So if you had the CT scan within 2 to 3 hours of your original injury, then you were more likely to find a bleed on a repeat. If you had a concomitant subarachnoid hemorrhage, if you had a subdural hemorrhage and an epidural hemorrhage, or you had extravasation of contrast on a CTA, these were all supportive of likely having progression on the next scan. They also describe something called the multihematoma fuzzy sign, which kind of has a long definition, but more or less, if you see mixed density hematomas, then this is a predictor of later expansion. Really, the vast majority of the predictive value goes to the severity of the initial TBI. So if you have a GCS less than 12, you're much more likely to have progression. But also, if you have some kind of coagulopathy or antiplatelet use, then these can also be risk factors. Now, the authors propose kind of a flow diagram as for when you should and should not repeat scans and at what time points you should or should not repeat the scans. But they don't say that they actually want anyone to implement this. They more suggest that they could integrate this with something like the brain injury guidelines, and that might better inform when you're doing scans to best support your patients. I think this makes sense. I think there's definitely modifications that can be made to the brain injury guidelines, and perhaps this could be something that could be done in the future. For myself, I think one of my biggest takeaways is going to be that if I scan my patient very early after they've had their head trauma, that I'm just going to be cognizant that they're likely to have some kind of progression, or much more likely to have progression over the next couple of hours because I got them to the scanner very quickly. This kind of data may be used to help better inform our repeat scanning protocols in the future, though. So in a spoonful, this systematic review better shows the nuances of intracranial hemorrhage progression on repeat CT heads. This has the potential to be integrated with clinical evaluations to best decide when and who to get a repeat scan on. Okay, that's all the articles this week. Let's do a quick summary just so we don't forget what we talked about. From the first article, How Do You Valsalva? It seems that the best way might be the modified Valsalva maneuver. That's probably going to be the most bang for your buck as far as this study showed. And then from the third article, we saw a review of intracranial hemorrhage progression timings. And so if you're looking to implement protocols in your emergency department, you should have a look at this article and their flow charts to decide when and for who actually need scans. Now, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What are those articles about? You missed their summaries. One of them was about trying to do paracentesis with a midline approach. Another was about how much opioids we've been using. Have we been cutting down because of the epidemic? And then lastly is how much naloxone we've been using. Also an interesting subject. If you'd like to get more summaries every week on the podcast, you'll have to become a member. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.